She could not feel her hands. Not the pins and needles that come from sleeping in a strange position. Not the momentary numbness that fades in a few seconds when you shake your arm out. She could not feel them at all. And then, within hours, the same thing began happening in her feet. By the following morning, she could not walk without falling. Her legs were giving way beneath her. And the terrifying part was that she had been telling her doctors for 2 years that something was wrong. She had been told it was anxiety. She had been told it was fibromyalgia. She had been told she was deconditioned and needed to exercise more. Not once had anyone sat down and said what her body had been screaming at every appointment. Not once had anyone said those 2 words. Nerve damage. What happened to her was not rare. In fact, what you are about to learn may explain symptoms you have been carrying for months or even years without a single doctor connecting the dots, because Sjögren's disease does not just cause dry eyes and dry mouth. It attacks the nervous system, and it does it in 4 distinct ways. Each one more dangerous than the last. Each one with a different pattern. Each one with a different window of time before the damage becomes permanent. Stay with me, because by the end of this video, you will understand something that most rheumatologists will not tell you, that most neurologists do not know to look for, and that the December 2025 clinical guidelines only just began to address officially. You are going to know which of these 4 types may be happening in your body right now. And you are going to know what can actually be done about it. I will walk you through the breakdown of all 4, so you know exactly what's what and what to ask for before your next appointment. I have pulled real patient stories, real data, and expert-backed diagnostic clues to help you figure out what your symptoms are really telling you. And if you want my downloadable symptom map, just type symptom map in the comments. The foundation: why Sjögren's attacks the nervous system. Most people who know anything about Sjögren's think of it as a gland disease. The immune system attacks the moisture-producing glands. The eyes get dry. The mouth gets dry. The skin gets dry. End of story. That is not the end of the story. Sjögren's is a systemic autoimmune disease. That word, systemic, means it does not stay in one place. It travels through the body and finds vulnerabilities. And one of the most significant vulnerabilities it has found, according to researchers and autonomic neurologists who have spent decades studying this disease, is the nervous system. Here is why. The nervous system has something called the blood-nerve barrier. Think of it as a kind of protective wall. Its job is to keep immune cells and toxins away from the delicate nerve fibers and their cell bodies. In most parts of the nervous system, that wall is strong. But there are specific locations where that barrier is significantly weaker. These locations are called the ganglia. The ganglia are essentially the headquarters of certain nerve types. They house the cell bodies of your sensory nerves and your autonomic nerves. And because the blood-nerve barrier is weaker there, Sjögren's immune activity can reach them in ways it cannot reach other parts of the nervous system. This is not a theory. This has been documented at autopsy. Researchers examining the tissue of Sjögren's patients have found that the large cell bodies inside the sensory ganglia and the autonomic ganglia are dramatically reduced in number compared to healthy controls. The immune system has been killing them. This is why Sjögren's has a particular pattern of nerve involvement that looks different from what you would see in diabetic neuropathy, chemotherapy-induced neuropathy, or any other common nerve condition. It does not always follow the rules. It does not always start in the feet and slowly climb. It does not always affect one type of nerve fiber at a time. It can appear suddenly. It can appear in unusual locations. It can affect multiple nerve types at once, and it can progress rapidly when the immune system decides to accelerate. There are 4 recognized types of nerve damage that Sjögren's may cause. We are going to go through all 4, starting at number 4 and counting down to number 1, because number 1 is the one that can put a person in the emergency room, and you need to know what it looks like before it reaches that point. Type 4, small fiber neuropathy. Type 4 in our ranking is the most common form of nerve damage seen in Sjögren's disease. It is also, by a significant margin, the most dismissed, the most minimized, the most likely to be written off as stress, as anxiety, as something the patient is imagining or exaggerating. It is called small fiber neuropathy, and it is real. It is measurable. And for many people with Sjögren's, it may have been present for years before anyone thought to look for it. To understand small fiber neuropathy, you need to understand what small fiber nerves actually do. The nervous system contains different types of nerve fibers that vary by size and function. The large fiber nerves, which we will cover shortly, handle things like balance, coordination, and precise touch. But the small fiber nerves handle something arguably more important to daily comfort and survival. They carry information about pain and temperature. They are the nerves that tell your brain when something is too hot to touch, when a surface is sharp, when there is tissue damage happening that you need to respond to. These nerves are either unmyelinated or very thinly myelinated. Myelin is the protective sheath that wraps around nerve fibers and helps signals travel quickly. Small fiber nerves have very little of it, which makes them efficient at carrying certain types of signals, but also makes them more vulnerable to immune attack. In Sjögren's disease, the immune system may target these small fiber nerves. And when it does, the symptoms can be deeply confusing. Burning pain in the feet. Electrical sensations in the hands. A feeling that the skin itself is on fire, or freezing, or both at the same time depending on the day. Sensitivity to light touch that should not be painful. The inability to tolerate the weight of a bed sheet at night. Feeling as though the feet are walking on gravel, even when the surface beneath them is completely smooth. These symptoms are real. They have a biological explanation. And yet a standard nerve conduction study, which is the most commonly ordered test for neuropathy, will frequently come back completely normal in someone with severe small fiber neuropathy. This is one of the cruelest aspects of this condition. The test that most doctors rely on cannot detect the damage that is happening. The correct test for small fiber neuropathy is a skin punch biopsy. A small sample of skin is taken, typically from the lower leg, and the density of small fiber nerve endings in that sample is measured. Research suggests that in Sjögren's patients with neuropathy symptoms, this test may reveal significantly reduced nerve fiber density, even when all other testing appears normal. Now, here is something important that gives people hope. Small fiber nerves can regenerate. Unlike some other types of nerve damage, the peripheral nervous system has a capacity for repair, especially when the underlying immune process is addressed. There are documented cases of individuals with Sjögren's who had significant small fiber nerve loss, who went on immunotherapy, and whose nerve fiber density returned toward normal ranges within months. The window for this kind of recovery exists, but it requires recognizing what is happening first. The clinical guidelines published in December 2025 addressed this directly. They stated that for patients with Sjögren's-related small fiber neuropathy that is progressive, severe, or not responding to symptomatic management, consideration should be given to intravenous immunoglobulin, or its subcutaneous equivalent, for a minimum treatment period of 3 months. That recommendation exists in writing now, which means when a doctor tells you there is nothing to be done, there is something to hand them. Small fiber neuropathy may be the least dangerous type in our ranking because it is the most common and the one for which the treatment pathway is becoming clearest. But do not mistake least dangerous for harmless. Untreated, it progresses. It spreads. And in some cases it transitions into patterns that are harder to reverse. Type 3, large fiber neuropathy. If small fiber neuropathy is the type that hides from standard testing, large fiber neuropathy is the type that announces itself in a way that is impossible to ignore, and yet still gets misattributed, misdiagnosed, and mistreated for far too long. Large fiber neuropathy in Sjögren's disease affects the bigger nerve fibers, the ones responsible for proprioception, which is your body's ability to sense where it is in space without looking. The ones responsible for vibration sense. The ones responsible for coordinated, controlled movement. When these fibers are damaged, the symptoms look very different from the burning and pain of small fiber damage. A person with large fiber neuropathy may notice that they are becoming unsteady. That walking in the dark is suddenly terrifying, because without visual input, their body cannot tell where the floor is. That they reach for objects and misjudge the distance. That their handwriting has changed. That buttons are difficult. That they stumble on flat surfaces with no obvious reason. Some people describe the sensation as feeling drunk without having had a drink. Others describe it as walking on a boat that will not stop rocking. These are not vague complaints. These are neurological signs that can be detected and measured. Large fiber neuropathy shows up on a nerve conduction study and electromyography, the very test that small fiber neuropathy evades. This is both good and concerning. Good, because it means there is objective evidence. Concerning, because by the time it shows up clearly on those tests, the damage has typically been progressing for a significant period of time. The pattern of large fiber involvement in Sjögren's may not always follow the classic length-dependent model either. In the typical model used to teach neuropathy in medical schools, damage starts in the longest nerves first, meaning the feet, and then slowly ascends. Sjögren's does not always cooperate with that model. Some patients develop large fiber symptoms in the hands before the feet. Some develop them in a patchy, asymmetric pattern. And when that happens, a physician who is only looking for the classic pattern may miss what is actually occurring. In terms of ranking, large fiber neuropathy sits at type 3, not because it is less impactful on daily life, but because it tends to progress more slowly than the types above it in our ranking. And because, with appropriate immune-directed treatment, the progression may be halted or slowed. The clinical guidelines support a trial of intravenous immunoglobulin in patients with Sjögren's-related immune-mediated large fiber neuropathy. If the immune system is driving the damage, interrupting the immune process is the logical target. Type 2, sensory ganglionopathy. We have arrived at type 2. And this is where the conversation shifts from serious to urgent. Sensory ganglionopathy, also called sensory neuronopathy, is one of the most severe forms of peripheral nervous system damage that any autoimmune disease can produce. Among those who specialize in this area, it is sometimes described in terms that make it sound almost unthinkable. One neurologist who has spent years studying Sjögren's and autonomic dysfunction has described it as among the worst, if not the worst, type of neuropathy that exists. Those are not casual words from someone who sees complex neurological cases every day. To understand why this type is so devastating, you need to understand what it targets. Unlike small fiber neuropathy, which affects the nerve endings, and unlike large fiber neuropathy, which affects the nerve fibers themselves, sensory ganglionopathy goes directly after the cell bodies, the neurons themselves. The ganglia. Remember what we discussed earlier about why Sjögren's targets the ganglia. The blood-nerve barrier is weaker there. The immune system can reach them when it cannot easily reach other parts of the nervous system. In sensory ganglionopathy, the immune attack is concentrated at the dorsal root ganglia, which are the clusters of sensory neuron cell bodies that sit just outside the spinal cord and relay information from the body to the brain. When those cell bodies die, the nerve fibers that extend from them also die. And unlike peripheral nerve fibers, which may regenerate with time and treatment, the cell bodies themselves cannot be replaced. This is what makes sensory ganglionopathy so catastrophic. Once those neurons are lost, they are gone. The clinical presentation of sensory ganglionopathy is distinctive and alarming. It does not follow the length-dependent pattern at all. It can begin in the hands. It can begin in the face. It can begin in the trunk of the body. It can appear in multiple locations simultaneously. A person may wake up one day with significant sensory loss in their hands and assume it will pass. It may not pass. It may progress over days and weeks to involve the arms, the legs, the torso. The sensory loss can become so severe that the person loses the ability to sense where their limbs are in space. Standing without visual input becomes impossible. Walking becomes dangerous. Activities of daily life become insurmountable. There is a specific neurological sign that sometimes accompanies this condition called sensory ataxia. The person's gait becomes profoundly unsteady, not because the muscles are weak, but because the nervous system has lost the ability to know where the body is without looking at it. Walking in the dark, turning off the lights, closing one's eyes in the shower, all of these become genuinely frightening. And yet individuals with sensory ganglionopathy may still have normal or near-normal standard blood tests. Their SSA antibody, which is the antibody most commonly associated with Sjögren's disease, may be negative. Research suggests that SSA positivity may occur in as few as 10% of Sjögren's patients who have peripheral neuropathy. 10%. Which means that if a physician orders an SSA test and it comes back negative and they conclude that Sjögren's is not the cause, they may be wrong in up to 90% of cases. Seronegative Sjögren's is real, and sensory ganglionopathy is one of the places where that clinical gap causes the most harm. The treatment window for sensory ganglionopathy is narrow, because once the neuron cell bodies are lost, the opportunity to recover function from those specific neurons is closed. This is why neurologists who specialize in Sjögren's emphasize treating this presentation aggressively and immediately. Intravenous immunoglobulin is typically the first-line immune therapy considered. In cases where that is insufficient, additional immune-modulating agents may be considered. The goal is to stop the immune attack before more irreplaceable neurons are destroyed. If you are watching this and you are experiencing sensory symptoms that are not following the typical feet-first pattern, that are appearing in your hands, your face, or your torso, that seem to be spreading in an unusual way, that are accompanied by unsteadiness or difficulty sensing where your limbs are in space, please do not wait to be dismissed again. This is the information you need to bring to that next appointment. Type 1. The medical emergency, vasculitic neuropathy. Type 1 is the one that moves fastest. The one that can become permanently disabling in a matter of days. The one that neurologists who understand this disease treat as a near emergency from the moment it is recognized. Vasculitic neuropathy is what happens when the immune system stops attacking the nerves themselves and starts attacking the blood vessels that supply the nerves. When the small blood vessels that feed a nerve trunk become inflamed and blocked, the nerve loses its blood supply, and a nerve without a blood supply does not survive. It infarcted. It dies. Just like a stroke in the brain causes brain tissue to die when blood flow is cut off, vasculitic neuropathy causes nerve tissue to die when its blood supply is blocked. This is why some neurologists refer to it informally as a nerve stroke. The clinical presentation of vasculitic neuropathy is often sudden and asymmetric in a way that is unlike any of the other types. A person may develop severe pain in one specific limb, frequently described as sharp, burning, deep, and agonizing, followed rapidly by weakness or sensory loss in the distribution of a specific nerve. It does not creep up slowly. It does not burn gently at the feet. It arrives, and it arrives with force. The asymmetry is a key clinical feature. While most neuropathies affect both sides of the body in a relatively symmetric pattern, vasculitic neuropathy may be dramatically one-sided, or affect different nerves in different limbs in an unpredictable pattern. This pattern is sometimes called mononeuritis multiplex, meaning multiple individual nerve injuries occurring at different locations and different times. If you develop sudden severe pain and weakness in one leg, then weeks later a similar event in one arm, then an episode involving a nerve in the other leg, that pattern is a signal that warrants immediate neurological attention. The stakes with vasculitic neuropathy are different from the other types. With small fiber neuropathy, the window for recovery is measured in months. With sensory ganglionopathy, the window is weeks to months. With vasculitic neuropathy, the window may be days. Once a nerve infarcts completely, the tissue is gone. Function in that nerve distribution may not return. Permanent paralysis. Permanent sensory loss. Permanent motor deficit. These are the real consequences of missed or delayed treatment. The treatment recommendation for vasculitic neuropathy is immediate high-dose glucocorticoids, steroids, at doses sufficient to aggressively suppress the immune-mediated vascular inflammation. This is not a situation where a physician can wait for further test results or schedule a follow-up appointment in 3 weeks. This is a situation where the treatment conversation needs to happen now. Here is what makes this particularly important for the Sjögren's community. Vasculitic neuropathy is not commonly associated with Sjögren's in standard medical education. When a doctor thinks of nerve stroke from vasculitis, they may think first of conditions like polyarteritis nodosa or granulomatosis with polyangiitis. Sjögren's may not even enter their differential diagnosis. And so the person sitting in front of them, who has been managing dry eyes and fatigue and abnormal blood work for years, who suddenly develops severe asymmetric nerve pain and weakness, may not receive the diagnosis and treatment they need in the time that they need it. This is why knowing this information matters. Not to replace a physician. Not to self-diagnose. But to be able to walk into that emergency room or that clinic and say the right words. To say that you have Sjögren's disease. To say that you have developed sudden asymmetric nerve pain and weakness. To say that you are concerned about vasculitic neuropathy and that you understand immediate treatment may be necessary. Those words may save your nerve function. In some cases, they may save your ability to walk. Recognizing your own pattern. Now that you know all 4 types, there is a question that may have been building since the beginning of this video. Which one might be happening in you? Knowing the 4 types academically is one thing. Recognizing which pattern, if any, may be present in your own body is something else entirely. And this is where you need to be honest with yourself about what you have been experiencing, and perhaps minimizing, for too long. Let us go through the patterns. Not to diagnose you, that is not what this is, but to give you a framework that you can bring to the right medical professional. If your symptoms are primarily sensory, meaning burning, electrical sensations, hypersensitivity to light touch, pain that is worse at night, temperature dysregulation in the skin, and if those symptoms are predominantly located in the feet and are symmetric, meaning both sides are roughly equally affected, and if you have had a normal nerve conduction study that your doctor used to dismiss your complaints, you may be looking at a small fiber pattern. The test you need is a skin punch biopsy. The treatment pathway exists, and nerve fiber regeneration is possible with appropriate immune intervention. If your symptoms include significant imbalance, difficulty walking in the dark, a sense of not knowing where your feet are unless you look at them, clumsiness that is new, a progressive unsteady gait, and difficulty with fine motor tasks like handwriting or buttoning, you may be looking at a large fiber pattern or an early ganglia pattern. A neurologist with experience in Sjögren's can order the appropriate nerve conduction and electromyography testing and assess whether your sensory pathways are intact. If your sensory symptoms are appearing in an unusual pattern, in the hands rather than or before the feet, in the face or the torso, on only one side of the body, in multiple locations at once that do not follow a predictable nerve pathway, and if you are developing difficulty sensing where your limbs are in space, or finding yourself unsteady when you close your eyes, that asymmetric, non-length dependent pattern may point towards sensory ganglioneuropathy. This is the situation that warrants urgent referral to a neurologist who understands Sjögren's disease specifically. Time matters here. And if you are experiencing sudden onset severe nerve pain, burning or stabbing in quality, in one specific limb or one specific region, possibly accompanied by new weakness in that area, especially if this has happened more than once in different locations over time, that combination of sudden onset, severity, and asymmetry is the pattern that requires immediate attention. That is the pattern that overlaps with vasculitic neuropathy. Do not wait for a scheduled appointment. This is an emergency department conversation. One more thing you need to know. You may have had an SSA blood test. It may have come back negative. And a physician may have used that result to close the door on Sjögren's as a diagnosis. But as we discussed, that antibody may only be positive in around 10% of Sjögren's patients who have peripheral neuropathy involvement. A negative SSA does not rule out Sjögren's. A seronegative patient with the right clinical picture still deserves a full investigation. That investigation may include a minor salivary gland biopsy, autonomic testing, skin punch biopsy, and evaluation by a neurologist who understands the full spectrum of how this disease presents. You have been carrying these symptoms. You have been told they are not real, or not serious, or not connected to anything treatable. They may be more connected, and more treatable, than anyone has taken the time to tell you. What treatment actually looks like. For decades, people with Sjögren's were told there was no treatment. That the disease simply had to be managed symptom by symptom. Dry eyes treated with drops. Joint pain treated with over-the-counter medication. Fatigue accepted as part of life. And nerve damage, when it was even acknowledged, managed with the same medications used for any neuropathy, gabapentin, duloxetine, and similar agents that reduce the perception of pain without addressing the underlying cause. Those symptomatic treatments have a role. For some people, they help significantly. But they do not stop the immune process that is damaging the nerves. They do not address the root of what is happening. And in the context of progressive nerve damage, addressing only the symptoms while the underlying immune attack continues is like mopping up water while leaving the tap running. The immune system is the target, and we now have a clearer roadmap than ever before for how to go after it. Intravenous immunoglobulin, commonly referred to as IVIG, is a treatment derived from the plasma of thousands of donated blood units. It contains a broad spectrum of antibodies that, when administered to a patient, may help modulate the immune system's activity in ways that are not fully understood but are clinically documented. In Sjögren's-related dysautonomia and neuropathy, there are documented cases of patients whose autonomic testing scores improved significantly after IVIG treatment. Not just symptom improvement, objective improvement on measurable testing. Patients who were bedridden returning to school and work. Heart rates that were climbing to dangerous levels with minimal provocation stabilizing after treatment. The December 2025 Clinical Guidelines for Peripheral Nervous System Manifestations in Sjögren's disease now formally recommend that IVIG, or subcutaneous immunoglobulin, be considered for patients with Sjögren's-related small fiber neuropathy that is progressive, severe, or not responding to symptomatic management, for a minimum trial period of 3 months. They also recommend IVIG consideration for immune-mediated large fiber neuropathy, and address its use in the context of autonomic neuropathy that is severe and not responding to standard measures. Rituximab, a medication that depletes a specific type of immune cell called B cells, may be considered as an adjunctive treatment in cases where IVIG is insufficient or cannot be given. For vasculitic neuropathy, the recommendation is high-dose glucocorticoids, initiated immediately. These are not fringe recommendations. These are published, peer-reviewed clinical guidelines. They exist in the medical literature. They can be cited in an appointment. They can be submitted as supporting documentation in an insurance appeal. And that brings us to the part of this conversation that is perhaps the most frustrating and the most important to understand honestly. Getting IVIG approved by insurance is often a battle, a long, exhausting, sometimes infuriating battle. Insurance companies frequently deny requests for IVIG in Sjögren's patients on the basis that there are no large randomized controlled trials proving its efficacy in this specific context. And they are technically correct that those large trials do not yet exist. The cost of running them is enormous. The infrastructure to do so has not been in place, and the advocacy needed to make those trials happen is still an ongoing effort. But the absence of a large randomized trial does not mean the absence of evidence. It means the evidence that exists is not yet in the form that insurance companies prefer to use as a reason to approve coverage. Peer review, meaning a physician-to-physician conversation where a clinician can make the case directly and cite the clinical guidelines and the documented case evidence, is often the mechanism through which approvals are ultimately obtained. If your physician is willing to go to peer review for you, that willingness may make a significant difference in your access to treatment. Physicians who do this work are not compensated for the time it takes. The phone calls, the hold times, the paperwork, the resubmissions. They do it because they believe in the possibility of improving a patient's life. If you have a physician who is willing to advocate for you in that way, that matters enormously. And if you do not yet have that physician, finding a neurologist with specific experience in Sjögren's and autonomic dysfunction is one of the most important steps you can take. Looking ahead. The landscape is also changing at the level of new therapeutics. For the first time in Sjögren's disease history, there are multiple agents currently in Phase 2 and Phase 3 clinical trials, agents that target different parts of the immune cascade, agents that may, if approved, represent the first FDA-cleared treatment specifically for this disease. Some of the most promising areas of investigation involve molecules that deplete or suppress B cells through different mechanisms, molecules that reduce specific types of immune signaling, and agents that interfere with the antibody-mediated processes that drive tissue damage in Sjögren's. The caveat that must be stated honestly is that many of these trials have not included robust neurological endpoints. What that means is that even if one of these agents is approved for Sjögren's disease, we may not immediately know how well it performs against the nerve damage specifically. That knowledge will take time to accumulate. But the fact that treatments are being developed and tested is a meaningful shift from where this disease stood even 5 years ago. What you now know. What does not require waiting is understanding your body more clearly than you did before you started watching this video. You now know that Sjögren's nerve damage is not a single thing. It is not vague neuropathy that cannot be specified or addressed. It is 4 distinct types, each with a different mechanism, a different clinical signature, a different level of urgency, and a different treatment pathway. You know that small fiber neuropathy is the most common and the most dismissed, and that it may respond to immunotherapy and even regenerate. You know that large fiber neuropathy affects balance and coordination, and shows up on objective testing. You know that sensory ganglioneuropathy is a fast-moving catastrophe that targets irreplaceable neurons and demands urgent action. And you know that vasculitic neuropathy is a nerve stroke that may cause permanent paralysis if missed, and must be treated as an emergency. You know that a negative SSA antibody does not close the door on Sjögren's. You know that new clinical guidelines exist and can be cited. You know that IVIG has documented objective benefit in this patient population, and that the guidelines support its consideration. And you know that the insurance fight, while real and exhausting, has pathways through it. None of this is a guarantee. None of this is a promise of a specific outcome for any specific person. What this is information. Real, sourced, clinical information that you deserve to have. Information that the medical system has been slow to give you. Information that could be the difference between the right conversation at the right time and another year of being told there is nothing to find. The symptom map and doctor visit action plan in the description below is one concrete next step. It will not replace a physician, but it may help you find the right one, have the right conversation, and begin moving toward answers, with something more than hope. With information. You have been carrying this longer than you should have had to. You have been dismissed more times than anyone should accept. The nerve damage that Sjögren's may be causing is real. It is measurable. And in many cases, it is treatable. The question is whether anyone takes it seriously soon enough. Now you know enough to make sure they do.